Welcome to this Urbe Group podcast, produced by our Medical Insight Studio. In today's episode, our Clinical Application Manager, Dr. Niklas Froemmel, is talking with Professor Venerino Poletti from Italy and Dr. Kishan Gonuguntla from India about an approach for which initial clinical feasibility data is now available. Various publications have reported on transbronchial cryobiopsy of mediastinal lymph nodes. Professor Poletti is head of the Department of Respiratory and Chest Diseases at the Ospedale G.B. Morgagni in Forli. He is also a member of the European Respiratory Society and often called to moderate international congresses. Dr. Kishan is lead consultant interventional pulmonologist at the Yashoda Hospital in Secunderabad. He was the organizing chairperson for the BRONCHUS 2021 Congress. In this episode, our guests are talking about their experiences with practical implementation of this biopsy technique. They go into what to watch out for and discuss what the current position is, in addition to the established EBUS-TBNA could be in terms of the therapeutic algorithm.
So may I start with you, Dr. Hari, your data and your experience on mediastinal cryobiopsy. What's the implication of that for your daily practice? So for which subset of patients are you using this biopsy technique frequently?
Hi, thank you for including me in the podcast. So my implication on this procedure, started trying to look at the feasibility of getting a lymph node biopsy through the miniature cryoprobe. And then we were successful in the first 4 cases with definitive diagnosis. So this procedure was followed after an initial EBUS-TBNA was done in the normal way using a 19 or 21 gauge needle and then followed by a small cryoprobe. So late, we started to include more and more patients to this procedure. And as an institutional protocol, we are trying to look at initial negative EBUS and then proceed those patients with cryobiopsies. But maybe in future, it can be the first procedure of choice after a lot of data gets evolved in the current, in the future.
It's quite a new technique now, and there are some technical issues still. So, Professor Poletti, what would you say, which level of experience does a bronchoscopist need to have to attempt a cryo-TBNA? What would you say?
Good morning to you all, and thanks for including me in this podcast. I think that you need to be expert in TBNA and in ultrasound-guided TBNA first. And you need to be expert also in the approach using intubation or rigid bronchoscope, because you need to extract all the bronchoscope with the samples in the tip of the probe. So you need to be expert in all these elements of the procedures. Yeah.
In case I deem myself sufficient, according to the characteristics that you have just mentioned, which lymph node stations would be rather good for beginners, and which ones would rather be something for more advanced bronchoscopists? What do you think, Dr. Hari?
I think to begin with, stations have to be more ideal, and choosing very large lymph nodes in the initial aspect would prevent complications, as this is a very new technology. And also, I suggest a station 11L is more easy for doing a cryobiopsy, and also 4R. A few lymph node stations like a 4L, because it is between touch vessels and sometimes you may not have control over the cryo, and even 11R superior in that way is for a more advanced bronchoscopist than a beginner level. So for the beginner, go on for the 7, 11L and 11R inferior.
This leads me to the next point. In which conditions would you deem a cryo-TBNA contraindicated? And I mean, we have very few data at this point, so of course, whatever you deem contraindicated may evolve still an indication in the future, but based on the current experiences and data, what are the contraindications in your eyes? Maybe Professor Poletti.
We don't have, I think, so far enough data to be sure about contraindication, but we follow the general contraindication of ultrasound-guided TBNA. So when you have a large lesion with necrosis, or you have some cyst, these are a kind of contraindication for using EBUS-guided TBNA. So I think this should be a prudent approach so far, yeah.
Dr. Hari, you have told me about the condition that you can have two larger vessels surrounding a lymph node and that a needle offers the benefit that it can bend more and therefore still puncture the node but not injure the vessels. How's that with a cryoprobe?
See, comparing the needle and cryoprobe, the advantages with the cryoprobe is flexibility of the EBUS scope. So some needles are like, the flexibility of the EBUS probe comes down, and then we are not able to access a few lymph, especially the Forli and the 10R lymph nodes. In that aspect, EBUS cryoprobe goes over EBUS needle. But when it comes to puncturing, sometimes the probe can slip when you're doing the EBUS cryo TBNB. So those things can be addressed in research by producing a bit more stiffer cryoprobes, maybe in the current, in the evolving time.
Speaking of slipping that you just said, I would like to move on to procedural questions and the procedural patient management. Has it happened to you that you've been slipping around the lymph node and maybe sampled the capsule instead? That's something we have heard so far. And how could this maybe be prevented? Professor Poletti.
This can be a problem because with the cryoprobe, it tends to be more tangential to the lymph node you want to biopsy. But anyway, I think that you can overcome this approach in two ways. You can help your assess using electrosurgery, cutting the mucosa. This is the first point. And the second point is just to move a little bit the bronchoscope in order to avoid this approach. But I think it's not so important because it's very unusual to have such kind of fibrosis in the capsule of the lymph node. So you need just to know that with the cryoprobe you tend to be more tangential compared to the normal needle you use.
As a pathologist, let me ask you this question. Which area actually do we need to have from a lymph node we puncture? Do we need the subcapsular area or do we need the hilar region?
This is a good point because we know that metastases usually start in the subcapsular senesis of the lymph node. So to stay just subcapsular is quite good from the pathological point of view, mainly when you are dealing with epithelial tumors. Also, if you are dealing with lymphomas, to be subcapsular usually is quite useful because the lymphomas infiltrates tend to go through the capsula. So yes, I think that it's not so important to be central in the lymph node when you want to capture the lesion.
You have mentioned it a bit earlier, Dr. Hari, for the necrotic lymph nodes. You see a bit of a contraindication or also in cystic conditions. Can you elaborate on this a bit more, why we should avoid cryobiopsy in such conditions?
It's not just with the cryobiopsy, even for EBUS-TBNA needles. If you look at puncturing a simple cyst is not really indicated. It's a quite surgical resection is the diagnostic choice. As you know, if there is a lot of necrosis and you do EBUS, the chances of mediastinal abscess formations are more with the previous experience from EBUS-TBNA. But overall, if you look at the complications that are mentioned in the ACQUIRE registry, they are less than 1% for conventional EBUS-TBNA. As the literature evolves, I think the same should apply for EBUS cryo-TB CNB as well. At this moment, since this is a new technology, we are not very aggressive on doing on these necrotic nodes. Maybe in the coming days, we try to do and see what complications can arise.
Professor Poletti, you have managed a bit earlier that you need to be advanced when it comes to airway management and that you are doing it in rigid intubation. So what are the anesthesiological requirements from your side? Why are you doing it in a rigid way? Can you please give us an insight about that?
Yeah, we use rigid intubation also with the normal EBUS-TBNA because we have this kind of facilities, but the needs for general anesthesia are not so complicated. You need to use propofol, remifentanil. The patient maintains spontaneous breathing, and so you can intubate the patient after local anesthesia of the vocal cords, and then they are already sedated with propofol. We don't use jet ventilation, for example, because the patient maintains their spontaneous breathing. So I think you need, of course, very equipped endoscopic room, but we do this approach quite frequently, even when we use EBUS-TBNA, not cryo, EBUS-TBNA. So I think this is a normal approach we use already.
Dr. Hari, what's your approach to that, and can you elaborate on this a bit more, please?
I think the way you do the procedure depends on the institutional policies. If you look at the West, like Professor Poletti said, they do most of the EBUS-TBNA under general anesthesia. But as our institution, we do using a supraglottic device. But I think by this time, with the 2 papers on EBUS cryo TB-CNB, it is already established that this procedure can safely be done even under conscious sedation. So it depends on where you're practicing, but this procedure can be done either in conscious sedation or general anesthesia using a supraglottic device or a rigid bronchoscopic intubation.
Facing this rather, let's say, heterogeneity that you have just displayed, what is your post-procedural protocol? So how do you monitor? Does the patient stay in the post-anesthesia care unit? Do you perform a chest X-ray afterwards, etc.? Professor Poletti, can you tell us how you do this with your patients?
We perform this approach in outpatient setting, so the patients remain in our institute for 2-3 hours after that, and we don't perform chest X-ray but only if clinically needed. So usually we don't perform any assessment. We just observe the patient for 2 or 3 hours after the procedure, and then we dismiss the patient at home. Yeah.
How about you, Dr. Hari?
Yeah, we also do the same protocol. Like we do observe them in the post-op area for 2 to 3 hours, like normal EBUS. But in the initial days, we were doing chest X-rays as this is relatively new technique. And then now we are changing to adopt not to do an X-ray as we see that there is no immediate complications we saw in our patients.
Professor Poletti has mentioned that the incision to the airway wall using electrosurgery might be one possible approach. We have heard some doctors raising concerns about damages to the ultrasonographical transducer at the distal end of the EBUS bronchoscope when you A, incise with electrosurgery, and B, also rapidly extract the scope along with the cryoprobe like we know from the peripheral transbronchial biopsies. How is your experience with that, Dr. Hari?
We till now has not practiced doing incision and then doing a biopsy. Maybe we need to try that. But I think the incision need not be done using an EBUS scope. It can be done with a flexible scope and then change it to the EBUS scope to prevent damage to the EBUS scope. And also what we trying to do is like once we pass with the needle, once the needle is in, we are trying to extend the site of perforation by just flexing and extending the EBUS scope so that we can avoid doing an extra electrosurgical knife perforation. So that is one technique we are trying to see the feasibility. And I think that should work. Like in cases where we are not able to pass, I think electrosurgical options can be tried. But EBUS scope damage with this technique is relatively not very significant, I guess.
Yeah.
When you pass... Sorry, please, Dr. Hari.
Yeah, and also the probe lies very far from the tip of the EBUS scope. when you're freezing and bringing it out. So I think as a procedure itself, it is very safe to the scope also.
Just to add something, when you use electrosurgery cutting, because when you collect material using the cryoprobe, the size of the samples is quite large, and so in this way you have enough room not to lose the material when you go out, when you throw out the bronchoscope. Yeah.
Yes.
The sample size, of course, always is subject to also the probe size and the pressure of the carbon dioxide. So based on your experience, how long would you freeze before extracting the endoscope and the cryoprobe, Professor Poletti?
3-4 seconds.
And
this is the freezing time we normally use, yes.
And with this
Of
freezing
course,
time, you're still able to extract the specimen through the puncture hole?
we use this freezing time. It depends also on the pressure you have in the bottle, but of course you need to have at least 60 bar of pressure. But with this freezing time, we obtain good samples. So we don't have experience with other freezing times. We use longer freezing time when you use the 1.1 cryoprobe in the periphery of the lung. But in the mediastinal lesions, we use this freezing time. I do not know if Dr. Ari has the same experience.
Yeah, Professor, we also in the initial cases, what we did, we were using only 3 to 4 seconds, and all the cases we were able to demonstrate good sample size with a freezing time of 3 to 4 seconds. And also I noticed if you freeze it for a very long time and not incising and going through the same hole, sometimes the shaft of the EBUS becomes very cold, and then it gets stuck to the bronchial mucosal wall. So that is one thing for disadvantage if you're using for a longer freezing time.
Very valid point. Thank you, Dr. Hari. Looking at the complications, and when I was reading the publication of the group of the Thorax Clinic in Heidelberg and the Chinese working group, I was surprised that the reported bleeding rate was so low. Gentlemen, what's your hypothesis on the rationale behind this low reported bleeding rate? Why is that, Professor Poletti?
I think that cryo technology is used to avoid bleeding, or to control bleeding. So we have bleeding when we have biopsy in the periphery of the lung, because you tear the bronchial artery or the pulmonary veins or the pulmonary artery. But in the mediastinal lesions, first of all, you can control the vascularization by ultrasound, and then usually you have biopsy not in area in which you don't have a large vessel. So I think it's very easy to have a very low rate of bleeding in this context.
How do you think about that, Dr. Hari?
If you look at the active registry for the conventional EBUS-TBNA, the bleeding complications, that means male bleeding requiring intervention, is only less than 0.2%. So as Professor said, this is not a TBNA where you have peripheral TBNA where you have bronchial and pulmonary supply, and then we are biopsying that area where bleeding can be anticipated. But in a lymph node, if you choose a proper lymph node with low vascularity and avoiding the areas of vessels in the lymph node, I think a bleeding should not be a problem with mediastinal cryobiopsy as well.
In your eyes, especially when you do the approach with the electrosurgical incision, you're going to have a larger compromise to airway patency than you would have with only the needle puncture to pass the cryoprobe. Is mediastinitis, in your eyes, Dr. Hari, an issue when doing the cryobiopsy here?
My case series is still evolving, and I need more time to have an answer on this, because till now we are just following up the patients who are undergoing these cryobiopsies. So I need more time to have a specific answer on mediastinitis related to cryo-TBCNB.
Are you undertaking prophylactic measures to prevent mediastinitis, like antibiotics that you administer before the procedure?
In our institutional protocol, we don't routinely administer antibiotics pre or post EBUS procedure, and we continue to follow the same protocol or cryobiopsy as well.
So we move on to the pathological considerations, and I think it's very beneficial to have you here, Professor Poletti, as you are demonstratingly a very good pathologist as well. So have you made any agreements with your pathology department in Forli on this new sampling technique as opposed to the TBNA?
I think that we had already a very large experience with cryobiopsy in the periphery of the lung, so we have no problems dealing with this kind of samples, and they are very normal samples. What I can say about from the pathological point of view is that usually when you have an epithelial tumor, you have enough material, in the majority of the cases at least, using a traditional approach with EBUS-TBNA. This new approach can be very helpful when you need a diagnosis of lymphoproliferative disease or even a benign disorder, maybe granulomas in the context of sarcoidosis versus tuberculosis or atypical mycobacteriosis. So I would say that this approach, so far at least, is mainly devoted or useful for diagnosis of annulus or complicated lesions, starting from lymphoproliferative disorder to other rare tumors. Primary tumor is the mediastinum, or benign lesions. Regarding epithelial or metastasis, the material you collect with the normal approach is good in the majority of the cases. We don't know in the near future. Now we are using NGS analysis for all tumors in primary or secondary epithelial tumors in the thorax. So I don't know exactly what will be the role of this new technique in assessing the molecular profile of tumors, because of course you have much more material compared to the normal EBUS-TBNA.
Dr. Hari, what was your pathologist's first reaction to this new samples?
Definitely my pathologist, especially when it comes to malignant nodes or metastatic disease, they will be more happy because size is a very big advantage here. We definitely get more sample than the conventional needles. But we have to see, being a TB endemic country, how this technology evolves. Especially, I am more interested in patients with a TB lymphadenopathy, where conventional EBUS-TBNA comes negative, and then we have to see if the cryo-TB CNB can be superior to the conventional TBNA in that aspect.
Do you provide your pathologist additional information when he gets a cryo-TBNA sample?
Yeah, we specifically tell them like we are going to do a cryo or TB-CNB in these patients, and then keep them informed. With our samples, what we have processed, as Professor was discussing, we were able to demonstrate molecular markers in all our samples when we perform EBUS-TB-CNB.
Professor Poletti, when you think of the rapid on-site evaluation, do you think that we need to go for a heterologous approach, meaning performing needle biopsy and cryobiopsy in the same patient?
The question is that if you still use a Rose analysis of the material, even during the cryo mediastinal lymph node, the answer is yes. We tend to reuse a Rose approach in all cases, and we have some experience now, not in the mediastinal biopsy, but in biopsy of the peripheral lesions of the lung using 1.1 cryoprobe, and we have some experience with the Rose using this material. If you wait a little bit and you can just smear one of the biopsy in a slide, you can have Rose analysis of the material. We don't have this experience with the cryo biopsy in the mediastinum, but in the periphery we have already this kind of experience. But I suggest to use Rose always, because first of all, you know if you are in the right position, if you collect lymphocytes or other specific material, but you also need this information to address further investigation. If you need cytofluorimetric analysis, or you need some kind of specific immunohistochemistry or molecular analysis, yes.
When you say we can use samples from cryobiopsy for rows, is it the other way around possible to increase the yield of needle biopsy when you, for example, increase the number of back and forth movements of the needle inside the lymph node? Dr. Hari, what do you think?
I think this is very interesting to look at. Rows may be not for looking at the diagnostic differences, but definitely shortening the procedure time we use. But with evolving technologies like the imprint cytology and also, as Professor was mentioning, doing rows from the samples, what they're getting from the peripheral TBNA. I think that technology, when it applies to EBUS-TBNA as well, it might be useful. At this moment, we also tend to do rows and then followed by EBUS cryobiopsy for histopathological analysis. I think in future, more data is needed on how many number of cryobiopsies are needed for diagnosis. That one thing has to be standardized with time and more case numbers. And again, should this procedure be followed by a EBUS-TBNA or not? That question again needs specific answers in the coming future.
I agree with Dr. Hari. We need, of course, more information and comparison between regular EBUS-TBNA and cryo-TBNA. And we need to assess exactly what is the best approach and to differentiate the utility of the two different approaches. Yeah. But we need more information, a larger experience in order to have this. And we need prospective studies.
So with that being said, thank you very much, Dr. Hari Kishan and also Professor Poletti, for this interesting discussion. It was great to hear you, as two of the innovators of this technique, discuss the advantages and disadvantages, and we look forward to further evolvement of the technique, to further data, and to see where it finds its niche in the diagnostic algorithm. Thank you very much, gentlemen, and we hope to hear from you.
Professor Poletti and Dr. Hari Kishan currently recommend transbronchial mediastinal cryobiopsy to any bronchioscopist who has experience and confidence in performing this EBUS-TBNA. In cases of granulomatous and lymphoproliferative diseases, the features of biopsy specimens procured using this technique can prove to have advantages over those provided by needle biopsy. Further standardization in regard to accessing lymph nodes, airway management, and anesthesia protocols, as well as patient selection, is yet to move forward. Crucial additional data will potentially bring answers regarding such issues in the future. Thank you, Professor Poletti and Dr. Kishan, for sharing your experience, which will be beneficial for other bronchioscopists as well, and Niklas for being here today. Have a look at their latest study in Respirology Case Reports 2021. Stay tuned for our upcoming episodes. Thank you for listening to our Medical Insights podcast, a podcast by the EBUS Group. To get further information and view our terms and conditions, please visit our website at www.ebus-med.com.